are a healthy lifestyle service provider. We've been operating for around about 17 years now. We run various services throughout the country, including a number of NHS-funded services. We're also a successful public health provider, and it is great to see a number of people on the call today who have got a background in local commissioning and public health. So thank you for joining us today. I appreciate lots of you are probably on your lunch break, so really appreciate you taking that time to come along today. Thrive Tribe is an ambitious organisation. We've got an aim to help over 1 million people to thrive and build long-term behaviours to support their health and well-being for the long term. And as you can see here, we are already a third of the way through achieving that ambition, which is incredible. We run a number of services throughout the country, as I mentioned, including healthier you services alongside things such as stop smoking and health checks. So specifically in relation to Healthier You, we are a provider for the National Diabetes Prevention Programme. We're currently contracted to provide that service for 7 ICB areas. And as you can see on the screen here, the areas we cover are Cornwall and the Isles of Scilly, Cambridgeshire and Peterborough, Derby and Derbyshire, and then 4 of the 5 London boroughs, so North East, North West, South East and South West. Due to our provision of the NDPP, we're really excited to be taking on 2 new programmes. One of those is the long-term conditions pilot, which we are working with a few of our ICB areas on in the new year. However, what we're specifically here to speak to you about today is the introduction of the behavioural support for obesity prescribing programme, or wraparound care programme for patients who are prescribed Mounjaro. It's a new programme. It's only been live for around about 3 months now, but we're really excited to take you through what the programme is and how and why it can support your patients through the webinar today. So for the webinar today, I'm going to hand over in a second to Dr. Richard Pyle, who is our clinical director. And in a moment, he's going to take you through why wraparound care is important and some of the research and evidence we have on how it supports patient outcomes longer term. And then we're going to take you through what the BSOP programme is, how it differs to NDPP, and some of the content changes to that programme. And also importantly, how you can refer your patients to us. So for now, I'm going to hand you over to Richard and let him take you through the first part.
Thank you very much, Emily. Welcome everyone. Brief reintroduction again. I'm Richard. I am a GP. I suspect doing the same job as some of you on this call. Thank you again for joining us in your precious lunch break, and to all of your precious lunch breaks, whether you're a GP or not. And as well as being a GP, spends most of his time working in general practice for the NHS. I'm also a lifestyle medicine physician and the medical director of Thrive Tribe. I'm going to talk today about the wraparound care for Tirzepatide or Mounjaro, as it is here upon us. I think it officially was upon us in June onwards, wasn't it? But as we know, it's in various states of advancement across the UK, as you will have seen from various news headlines. Can I have the next slide, please? So why even bother? You know, we've got these miracle drugs now, and let's be honest, they are pretty miraculous if you take the headlines. We're talking about 20% weight loss on a drug like Tirzepatide, with apparently potentially hundreds of other weight loss drugs in the pipeline coming out within the next year, 2 years. Some of them orally formulated as well, so you won't even need to inject yourself. And it is undoubtedly a major step forward. Those of us who are like me a little bit longer in the tooth will remember, not the amphetamines, that was before my time, but drugs like sibutramine, orlistat, which we're still using in primary care at times, but these were not miracle drugs. They had a limited effect and often not particularly well tolerated. We'll get onto that in a moment. But the question is, why bother when people are losing 20%, when people are microdosing, when you're seeing celebrities on it who aren't even overweight? What is all this about? And of course, we believe at Thrive Tribe, the answer is it's really, really important, which is what I'm going to talk to you about. Next slide, please. So I'm not going to say, to quote the verb, the drugs don't work, because obviously they do for some people, but the drugs have limitations. Side effects are a significant issue as well. We know that even in trial data, and bearing in mind these are people who've been recruited to trials, and therefore they usually have the most positive outcome compared to real world data, about 50% of people discontinue these drugs in about a year. And I've certainly seen that in my patients. Some of them have only managed a few days or a few weeks. So they do have limitations, and people will need support through that, depending on the severity of it. Although obviously we will explain in the discussion today that ultimately significant side effects we do refer back to the provider, who, of course, who is the prescriber, who is responsible ultimately for having done that. There is also no long-term data for safety or efficacy with these medications. We've the longest that they're commissioned to be used for, or licensed, I should say, to be used for, is about 12 to 18 months, maybe a bit longer. And you are right if you're being a little bit cynical at the moment and thinking, well, in reality, we're going to end up taking these drugs forever, aren't we? That's what will happen. That's what the drug companies want to happen. But at the moment, that's not what they're licensed for. And so not only do we not know about how safe they are in the long term, but people will need support when the time comes to come off the drugs. Because as is mentioned on this slide, weight loss off the drugs is common, it's rapid, and it's substantial. So how can we help those who are, whatever the setup is in your ICB in your locality, those who are running a weight loss clinic, those who are prescribing the weight loss injectables, how can we support the patients and those who are doing that? And it's also worth remembering, of course, that these drugs are just drugs that address a symptom. Whether you believe obesity is a disease, whether you believe it's a symptom, whether it's somewhere in between, it is essentially a symptom, and it is an outcome of lots of different factors in a person's life. Adverse childhood experiences, living in an environment where the food is of poor quality, insufficient education, other health problems that make it more difficult, and poverty, for example. And these drugs do not address those root causes. And so that, again, is the holistic approach that we pride ourselves on taking at Thrive Tribe. Next slide, please. So why is behavior change important? What is the evidence for this? We believe it is. It's something that we focus on particularly heavily at Thrive Tribe. Well, just a little table summarizes it quite nicely. It compares people in terms of the benefit with and without behavioral support who are taking these medications. And you are significantly less likely to regain the weight after stopping the meds if you have support. You are more likely to maintain that weight in the longer term. And your resilience potentially is improved as well, which again will help you to perhaps keep that weight off, as well as manage some of the other challenges in your life. Without support, you're more likely to regain the weight, to regain it quickly. The changes you've made, if you've made any, are potentially much less sustainable, and you're probably a bit more vulnerable to relapse, hence the value of the support service that we're offering. Next slide, please. And I've touched upon bits of this already, but we need to always think about emotions and mental health as the root cause of support. And I often will say to my patients when we're talking about weight generally, whether or not they meet the criteria for being prescribed for at the moment, which, as most of you will know, is a very, very small proportion of the population. Sometimes actually it's right to address those root causes first before you even start talking about, whatever you're putting on your plate and what your portion size is and whether you're going to take these drugs. It's important to address those underlying issues, and that's where psychological support from a wraparound service can be helpful as well for people, okay, who are on the drugs already, but that isn't the whole story. And actually being supported, being in a group with people, or at least having a one-to-one support, is really powerful for your motivation. It makes you more accountable. And we know from all the principles of behavior change that you are more likely to succeed if you have that support around you. Next slide, please. So I believe firmly that the holistic approach, which we take at Thrive Tribe, is really important as well. These are my pillars of well-being. They're slightly different from the British Society of Lifestyle Medicine. I think they stick purpose in the mental health bit, and they have something about avoiding noxious substances. But these are the pillars that I talk to my patients about in and outside of the NHS. Purpose, sleep, connections or relationships, movement. We like to say that rather than exercise. Stress and relaxation, how that's managed, getting the right dose of stress and your response to it. And eating well, of course, highly pertinent to today's conversation. If we just focus on the nutrition pillar and we ignore the others, we are very unlikely to be successful. And I have run courses both in and out of the NHS where we have actually taken people at higher risk of cardiovascular disease and other outcomes we don't want. And over, for example, a 4-week period, we've run courses where we talk about the pillars of well-being, and we talk about the evidence for lifestyle medicine, and we talk about the principles of behavior change, and we don't lecture them on weight, and we don't weigh them and check their blood pressure. And yet, a year later, some of these people have still reversed their pre-diabetes, lost weight, improved their blood pressure, improved their blood sugar and their cholesterol. So this rounded holistic approach is really important because that's what we are as humans. We don't just address one facet of our lives. Next slide, please. And here is some hard data for you. These were from the SURMOUNT and the SURPASS trials, which were specifically done on tirzepatide and weight loss, so exactly pertinent to what we're talking about today. And as you'll see from this simple simple graph that I put together, if you look at the percentage weight loss on the y-axis and the dose of tirzepatide on the x-axis, whether it was placebo, whether it was 5, 10 or 15 milligram dose, the people in the SURMOUNT study who had wraparound care did significantly better in terms of their percentage weight loss, double or more than those who just took the pills or the injections, as is the case of this medication. Hence the conversation today. And without further ado, I will hand you over to my colleagues who are going to explain a bit more about how it all works.
Thank you ever so much for that, Richard. So yeah, we're going to take you through an overview now of what BSOP or wraparound care actually looks like. So this programme was commissioned by NHS England following new guidance that was published by NICE at the end of last year, so at the end of 2024. And that guidance highlighted that Tirzepatide or Mounjaro by its brand name could be prescribed through primary care settings, whereas previously it was only available through secondary care. However, that it needed to be accompanied by behavioural support. What this meant in real terms was that NHS England needed to establish a support pathway in a relatively short amount of time. So they reached out to all 4 of the NDPP providers and asked that an amended NDPP offer be created for this new audience group. So these are patients who are eligible for Tirzepatide. We're going to take you through the eligibility in a little while, but potentially quite complex patients. And so we've had to work to adapt a programme to suit their needs. It's currently an interim service until March 2026. However, we don't anticipate that there will be a gap in provision, and it will likely be wrapped up in whatever NDPP's new framework looks like as we go through 2026. Next slide, please, Tilly. So to give you a bit of a brief overview of the programme, it's a 10-month, 300-day behaviour change programme. It follows the same structure and overall design as NDPP. So for those of you that are familiar with NDPP and have referred patients into that pathway, it follows a structure of 13 behaviour change sessions over the course of those 10 months. The content of that programme, as I said, has been amended for this particular audience, and Bex is going to take you through a little bit more about that shortly. The difference to NDPP is due to each ICB being at a different stage in terms of their referral and their prescriber pathways. We didn't want patients to be waiting to access support, so our provision is offered primarily online at the moment through a tailored remote provision, meaning that patients can be quickly triaged, enrolled and started on programmes from multiple locations across our 7 ICB areas with very minimal wait time. Whereas NDPP, we have to deliver that face-to-face, and so we have to wait for there to be enough demand in a given area to be able to put that provision on. However, that's not to say that where demand is or where need is, we can't work with local teams to explore a face-to-face provision if it's felt that would be better for that particular community, that particular location. However, at the moment, that online offering, as I said, means that we can get people into the programme quickly and swiftly and get that support in place for them. For patients who prefer a self-directed approach or perhaps a less structured approach, we work with our partner organisation at Second Nature, who offer the programme through an app-based platform, which allows patients to access the content more freely at time to suit them. So there are a few options available to them, and we'll work closely with patients on referral to establish which is the most suitable pathway for them individually. Next slide, please, Tilly. It's just really important to highlight that the behavioural support programme is very different and very separate to the prescriber pathway. So this table nicely highlights what those differences are. As we said, there is some variation in prescriber pathways. So some people are predominantly coming through GP referrals. In other areas, they're working closely with specialist weight management service to provide that referral pathway. However, the prescriber guidance is the same regardless. So from a clinical point of view, as a prescriber, the responsibility there is obviously around the clinical support, which involves obviously the prescription of Tirzepatide, ongoing support for patients in terms of side effects, and that might include the monitoring the dosage, titration schedules for those particular patients. It includes helping and guiding patients on safe injecting and how to manage their prescription, as well as maybe general information around nutrition and exercise, and of course hopefully encouraging patients to engage with the behavioural support programme and the benefits that that will offer. On our side, as the behavioural support provider, for us, it is about that, as I say, that behaviour change programme. So it's information around how lifestyle change and support can help them to manage and get the best out of their prescription, as well as helping to set them up for long-term success. There'll be some generalised information on the impact of Tirzepatide and signposting around that. We can give guidance on managing side effects and how some of that can be alleviated through nutrition and exercise. However, it's very clear that as practitioners and as an organisation, we will signpost back to the clinician, to the relevant prescriber, for guidance around medication, clinical symptoms and side effects. So there's a really clear definition between the two roles there for us. Next slide, please, Tilly. So as a prescriber, we will keep you updated on your patient's journey throughout. So we will notify you at the point we've received that referral of that patient. We will let you know if we have to cancel that patient. So for instance, if that patient, we haven't been able to engage them, so we are required to make at least 3 contact attempts to reach a patient using 2 different contact methods. If at that point we are unable to engage them, we may cancel their referral and send them back to the prescriber. We'll notify you when they've started a programme, and then again either when they've completed that programme or if they disengage during the course of the 10-month programme. So in terms of if they become disengaged, that is if they miss 3 consecutive sessions and we're unable to contact them, make any contact and re-establish that contact with them. Just to note, we do understand obviously life happens, schedules change, people's work commitments, family commitments do change, and patients may have to drop out of their current programme. However, they can be re-referred back in. But it's important to note here that if a patient does stop the programme or they do drop out and they do get re-referred, they will have to start at the beginning again. So they can't re-enter at the point they dropped out, if that makes sense. And they'll go back to session 1 and start the programme from that point again. So I think I'm going to hand you over to Bex now, who's going to take you through the programme content and how that's been adapted and changed to suit this particular audience.
Thanks, Em. Hi again, everyone. Yeah, I'm just going to take you over a bit of a kind of a brief overview to where we've adapted the current NDPP program. So kind of to reiterate what we've kind of been speaking about, you know, the medications kind of are a tool, but kind of not that kind of standalone fix. So yes, they do kind of reduce your appetite, your cravings, but they don't necessarily kind of teach our patients about kind of the long-term habits, and without that lifestyle change, the results that our patients are going to get are likely to be temporary. So yeah, we've kind of carefully kind of curated kind of the content, and we've, you know, weaved in kind of our, which I'll go over after this, kind of our 5 pillars that we stand by within Thrive Tribe, and we integrate into our program. So our nutrition, our movement, our sleep, our mind, and alcohol as well, very similar to Richard's, what Richard believes the kind of the pillars of health are, and we also kind of integrate in that kind of connection and purpose as well. So that's kind of what we've based the content around, and then obviously we've had to adapt some of our current DPP content to make it relevant to our patients on the BSOP program to align it to kind of what they're going through in terms of kind of their medications as well. So yeah, I appreciate these PDF screenshots are very small, but yeah, this just kind of gives you an idea of that we've got 2 syllabuses for our kind of our face-to-face Healthier You DPP curriculum, and then our BSOP as well. Tilly, next slide, please. So yeah, hopefully everyone's able to see this a little bit better, and I'll spend the next kind of couple of minutes just going over where we've adapted the content. So what we found as well with adapting the content is most of the changes, or most of the adaptations, actually fall within the first kind of, say, 6 sessions of our content. So in the first session, we talk about, and we've added in a little bit of information around kind of how Tirzepatide can support your weight loss journey. So again, just reiterating that, you know, they're a great tool to kind of assist and support your weight loss. But we also kind of highlight the importance of healthy lifestyle changes alongside the medication. We also talk a little bit around our approach and thinking about your why as well, thinking about that intrinsic motivation. We talk a little bit around kind of your weight loss and expectations whilst on the program. And also kind of introduce goal setting and micro goal setting in this session as well. The second session, the additions that we've added in are the importance of eating well whilst on the medication, and how to do this on a reduced appetite as well. So really highlighting that when losing weight with weight loss medications, you know, your body requires adequate nutrition to kind of preserve that kind of muscle mass and bone density, kind of maintain those stable energy levels. You know, most importantly as well, kind of avoiding micronutrient deficiencies, and support kind of proper immune function and hormone function as well. And what we kind of go into as well is how to prioritize that nutrition when you have that reduced appetite, which naturally will come with being on Tirzepatide. So you know, going over kind of practical strategies like trying to establish kind of a structured eating pattern. So rather than kind of waiting for those hunger signals, which are likely to be suppressed, trying to aim to kind of eat every kind of 3 to 4 hours. Also kind of making food more manageable as well. So, you know, smaller portions, making food easier to eat. And also, you know, maybe having kind of, you know, smaller meals, but more frequent. And prioritizing kind of easy to digest foods as well. We also talk a little bit in session 3 about how to eat well when experiencing side effects as well. So we touch on the kind of the main side effects that are quite common within taking weight loss medications like Tirzepatide, so things like nausea, constipation, tiredness, and we go through kind of practical ways that how your food nutrition can help kind of manage some of these. and help kind of alleviate these. So again, things like eating smaller, more frequent meals, increasing kind of fiber from whole foods, and prioritizing hydration as well, and making sure that we're having consistent protein intake throughout the day as well, and including iron-rich foods to help with tiredness. What we do really emphasize as well is that there's only so much that we can kind of guide on, and I know Em went through kind of the different levels of support in terms of the clinical and the behaviour. So yeah, really just reminding patients that that if they have other kind of side effects, or the side effects don't ease, they're getting things like persistent sickness, or kind of inability to kind of keep fluids down, or anything like that, that they need to kind of go back to their healthcare provider or prescriber to speak about their dosages, or their medication. We also have a nice conversation in session 3 around kind of how Tirzepatide or weight loss medications in general can have an impact on and change your relationship with food, which my kind of current experience with delivering the program so far, I have found quite interesting. So it does have that effect, which is what I've found with patients, is that it does change the way they think about food, and that reduction in food noise as well. So yeah, just having that kind of open conversation as well around how it can impact their relationship with food in both a positive way and a negative way. In session 4, we have really highlighted the importance of meeting your protein needs whilst on weight loss medications as well. So specifically talking about protein, and kind of getting patients to kind of understand, whilst they're taking the Tirzepatide, their body's protein requirements remain essential, even as that appetite decreases as well. Highlighting our guidance as well, which aligns with the research in terms of for most people taking Tirzepatide, kind of aiming for around kind of 25 to 50 grams of protein at each meal it can be really useful, as it kind of provides that foundation for meeting those daily needs, and also giving the patients some practical tips of kind of what that looks like kind of on a meal-to-meal basis. So giving them kind of examples of meals or meal plans, of what that breakdown would look like, and also giving them practical tools to include kind of more protein-rich foods that are easier to consume as well. So things like Greek yogurt, kind of soft-cooked meat dishes, tinned fish, and even things like smoothies and soups, and kind of what things you can add to your current meals to kind of boost their protein intake as well. We have adapted some of our current guidance on exercise as well. So we put more of an emphasis on kind of the importance of muscle loss whilst on Tirzepatide, and how to reduce this with the addition of around kind of 2 to 3 strength and resistance training sessions each week. And the benefits of this, and also kind of just giving them a little bit of support in terms of kind of how you can safely integrate this. So we've got videos within our program as well, and then we've also created a few extra resources to support patients who this is completely new to. Especially with the patients that I've currently got, a lot of them are quite immobile. So the thought of even, integrating a bit of strength and resistance training can be quite daunting. So making sure that they are armed with the right guidance, and that's sort of stuff that we are working on continuously, to kind of add in with that support in that sense. And then the last kind of bit of kind of adaptations is just learning a little bit about meal planning, and helping them, giving them the knowledge on the importance of not skipping meals as well, even with that reduced appetite, which is very easily done. Again, what I've found so far is a lot of the people on the weight loss medications aren't probably having around 3 meals a day. So helping them kind of meal plan can really help kind of reduce the skipping of meals. and also exploring kind of the importance of hydration as well, whilst on the medication, and kind of recognizing those signs of dehydration as well. So that is a very speedy overview of kind of where we've adapted the content. And this just gives you a little bit around kind of, yeah, how we integrate our 5 pillars, so our nutrition, our movement, our sleep, our mind, into the program as well. Thanks, Tilly.
Thank you so much for that, Bex. It's really useful to see a bit more about that. So just to talk you through a little bit around eligibility criteria for the BSOP programme. And I'll also talk to you a little bit about how to refer your patients in before we look at the Q&A section. The BSOP programme is currently only available to patients who are prescribed Tirzepatide through the primary care pathway on the Tirzepatide for weight loss pathway. As mentioned, there are numerous models across ICB areas that we support, but they must be on that pathway. At the time of referral, it's for the prescriber to decide if the dedicated BSOP programme is the most appropriate referral route, or whether that particular patient may benefit from additional support from elsewhere. So it could be that they are better suited to requiring additional mental health support at that stage through talking therapies. Being under 18. At the moment, we also cannot take patients who have an active eating disorder. If they have a history of disordered eating, then they can be referred, but at the moment we are unable to accept patients who have an active eating disorder. So if you can just go to the next slide, Tilly, thank you. There are currently very tight restrictions on who can be prescribed Tirzepatide and come through the pathway. So the initial cohort of patients that can be referred are patients who have a BMI of over 40 or 37.5, dependent on certain ethnic groups. However, alongside the BMI, they also must be living with 4 out of 5 of the following comorbidities. So there's hypertension, type 2 diabetes, dyslipidemia, obstructive sleep apnea, and atherosclerotic CVD. I was terrified about saying that word today. But yeah, so they must have a BMI of over 40 and then 4 of those 5 eligible comorbidities. We know that some surgeries are doing searches to identify eligible patients, so to identify which of their patients may be eligible and to do a review and speak to those patients and decide whether or not that's appropriate. One thing NHS England have been very clear about is that they do not want us as the behavioural support provider to question or further assess those referrals. So we won't be assessing BMI or what those comorbidities are. We aren't required to do that. We may double check if, for instance, the referral appears to be underage, for example, or there's a query over potential eating disorder. But that aside, it is for you as a prescriber to clarify that eligibility at that point. Next slide, Tilly. So how do you actually refer to us? So this will differ across areas depending on how your referral pathway is being set up and based on your local IT systems. However, most will use your local clinical system to use our pre-populating referral form, which you may already have. It may already be there on your system. And if it's not, it is probably in the process of being added at the moment. It's important to note for those of you that have been referring into the NDPP pathway, that it is a different referral form, because obviously we need to clarify eligibility, but it does come to the same inbox. So referrals still come to healthier at the Healthier You inbox that the NDPP referral forms come to. Next slide, please, Tilly. So this is a simplified view of our patient pathway, just to talk you through what that looks like. So at the point that you refer your patients to us, we process that referral usually within 24 hours. They receive an automated welcome email from us, and then they are contacted via telephone. Now, we may contact them via telephone and not get a response, in which case we will try on 2 more occasions to contact that patient. So that could be through phone again. We may follow that up with a text message, an email, in order to try and make all attempts to reach them. However, if the patient doesn't respond, or if on speaking to them they decline the programme, then obviously that referral is cancelled and you are notified of that. However, if we make successful contacts, they will be taken through a 20-minute sort of discovery call with our triage team, where they'll be guided through selecting the most appropriate pathway for them personally. So the options will be made available to them, and they'll be able to explore together what they feel will be the right fit for them personally. At the moment, as we said, referrals are being processed relatively quickly, within a matter of days at the moment. When that's, when those referrals pick up, then that process should take place with 1 to 2 weeks maximum at that point. Next slide, thank you. So just to kind of fill you in on our current position, and actually we're in a slightly different position to this slide as it is at the moment. We have referrals coming in from a number of ICB areas. We've got 2 that are currently actively referring regularly, and we're expecting another 3 areas to go live imminently in the next week or 2. As of this morning, when I checked, we've received 89 referrals so far, and as I say, they're currently all being processed in under sort of 24 hours at the moment. Over 48 patients have now started a programme, whether that be with ourselves or through the digital pathway, and we've got another 14 patients who are waiting to join programmes that start in the next few weeks. Uptake is really, really strong at the moment, much better than we've seen historically on the NDPP programme. Engagement has been really positive. I know Bex alluded before on her experience of working with patients already, as has myself. And so far, engagement is hugely positive. Patients are really engaged at the point they come to us, very excited to have the opportunity and to get involved. And yeah, kind of getting the benefit of that really quick, which is lovely. So we're in a really strong position. I should just really stress at this point, we are ready for receiving referrals. Our teams are in place, and we've got an excellent team of triage staff to process those referrals quickly, and an excellent team of practitioners ready to go with delivering those programmes. So we are absolutely ready to take those referrals, and obviously here to support you all in any way that we can, really. I can see there's a few questions starting to come through, so perhaps we can move on and start to take a little look at those. Go back to the top. Oh, Rebecca, I'm glad you found that helpful. She said, this is brilliant. Is it a service that we can direct patients to who are taking Mounjaro privately? Unfortunately, that's not an option at the moment. However, we're certainly aware as a provider that there's a gap and an opportunity to be explored there around how patients can access that support when they are purchasing Mounjaro privately. Fortunately, at the moment, that option isn't there, but we shall see if that's something that can be explored in the future. can we refer patients? Can we refer patients that have been identified as eligible for weight loss cohort but are already taking for diabetes? Jimmy, I don't know where we're at with that. I think we're waiting for clarification, aren't we?
So it's an interesting question, that one. So in theory, at the moment, you could not. So you couldn't refer someone who was getting Mounjaro for diabetes management for the weight loss program. However, we know of some of our ICB areas where there will be patients who are eligible for both pathways. There's slight differences. If they're on Tirzepatide for weight loss, they can get access to the behavioural support program that we offer, which, as Richard showed, is hopefully would provide them greater success if weight loss is their goal. And there are slightly different dosages available of Tirzepatide on either pathway, but at the point of prescription. So if I know that one of our ICBs that we're working with on this are basically going to give the patients the choice if they're eligible for both pathways. Have a discussion at the point of prescription and go, look, you're eligible for both pathways. You can get this dosage on this pathway, or you can do the Tirzepatide for weight loss pathway and get access to behavioural support as well. So someone who is on the diabetes pathway at the moment wouldn't be able to get access to it. I say that we literally had a conversation with our commissioners on BSOP at NHS England last week, because one of our ICB partners is hoping to use some of their funded BSOP spaces for patients who are being prescribed Mounjaro for diabetes. But that's with NHS England at the moment to make a decision on, and it's not our side to argue with them on. That would be between NHS England and the ICBs. We're obviously providing the behavioural support patients at the minute, people who are prescribed it for weight loss, but if they open that up a little bit so we can provide it to patients who are being prescribed Mounjaro for diabetes, that's excellent. We'll provide the best service we can to those patients, but we to a degree, we do what we're told slightly by NHS England there.
Thanks, Jimmy. Someone's asked for clarification of the areas that we cover, so I've just popped that in the chat box, so hopefully you can see that there. Priya's asked, I can only see the NDP referral forms. Again, dependent where you are, Priya, it may be that it's not quite there yet. Some of the areas are still working on their IT systems and getting referral forms uploaded. So if it's not there, hopefully it should be there very soon. But we certainly can circulate the referral form after this call, just so everyone's got eyes on it and can see what it looks like. And in terms of your patient, no, so type 2 diabetes. So as mentioned before, the eligibility criteria. So as long as they have a BMI over 40 and they meet 4 of those 5 comorbidities that we listed before, and type 2 diabetes is one of those comorbidities that listed. So dependent on the sort of the wider sphere of that patient's history, then they may very well be eligible. So it'd be worth just double checking against that eligibility to see whether or not she can be referred in for sure. I think you touched on this, but am I correct in saying that you would be recommended? No, so Joshua, to answer your question, that's not for us to, so we won't be recommending dose titrations. That's down to the prescriber to make those decisions. So we would expect that patients would be having regular check-ins with their prescriber, and they will review that together in terms of titration schedules and the decisions to be made there. So that is a decision that we wouldn't be involved in as a behavioural support provider. So I hope that answers that. My screen's frozen, Jimmy. I don't know if you can.
We can hear you, Em, yeah.
It's not letting me scroll down at the moment. It's completely
Okay, cool.
frozen.
So I think there's there's one more question from Philippa about who is leading the programs, and I guess will they be dietitians or what their qualifications are.
Lisa, do you want to take this one so we pop up?
Yeah, so the lead team that has developed this program, we're a combination of different people. So we have nutritionists, we have a lead dietitian, we have a health behaviour psychologist, and we have people like myself who have a raft of knowledge of delivering these programs. So we have a really good combination of different people who have engaged and brought into this team. Our practitioners who deliver are experienced practitioners in the diabetes prevention program at the very least. Many of them have qualifications around nutrition, dietitians, quite a few of them have behaviour change expertise, and internally as Thrive Tribe we deliver behaviour change training ourselves to a high standard and high level. We obviously have Dr. Richard Pyle, who is our clinical director, who supports us with the content that we put into these programs to make sure that they are correct and clinical and behavioural standards expected. So I kind of hope that's answered the question, that we've got a really good raft of experts in the room pulling these programs together and people delivering it.
Yeah, I think what I'd add to that, Lisa, so if we're to direct responses, then the staff delivering the programs won't all be dietitians, but they're supported by our MDT and our clinical group, like clinical directorate, which is a mixture of dietitians, of which there's several, physical activity experts, mental health, like mental health lead, and obviously Dr. Richard Parr, who you heard from earlier. We recognise as well that the client group on BSOP is probably going to be a little bit more complex than our regular NDPP programs. So we are effectively somewhat cherry picking our best practitioners from NDPP to lead on these. The first programs have only been led thus far by our clinical team as well, so we can make changes to any content after that. So not everyone leading the programs will be dietitians, but there'll be some of our expert practitioners who are fully trained and supported to deliver the programs that we've developed. It's kind of a similar question here around whether or not we have a clinical psychologist as part of our team. So we don't at the moment have a clinical psychologist within our MDT. We have a mental health lead who I think actually has just finished her PhD to become a clinical psychologist, which the PhD was done on some of our services and a bit of a review of them recently. We have in the past had multiple clinical psychologists who kind of helped develop some of the theory behind some of our programs, and actually a core part of the intervention. So Lisa and Bex, who are on this call, have worked with the National Centre for Behaviour Change. Their lead there, a lady called Kendall, was involved in designing our programs back in the start. And we also worked with Dr. Heather McKee. I'm not actually sure what Heather's a doctor in. Lisa or Bex might be able to tell me, but she's sort of one of the leading voices in behaviour change in the UK, and we did have her on board as part of the team designing some of these programs for quite a while, working with us to improve our interventions for a couple of years. So yeah, the services themselves, the sessions will be delivered by expert practitioners, but we have a robust clinical directorate behind all of that, either if we need to escalate anything or highlight any incidents that happen, but also to support our staff and make sure they're comfortable and that patients get the best experience they can. There is a question. Do you want me to read it out, Emma, or do you caught
No,
up
I can
again?
see it now. Yeah, I can see it now.
Right, you go for it.
So yeah, there's a question where, so Jen's asked if the patients are eligible with 4 of the comorbidities and a BMI of 40+, but they're on another GLP-1 such as Ozempic, should we be swapping them to Tirzepatide and referring via BSOP? Unfortunately, that's not something we can provide guidance on, so that would be down to you as their prescriber and their clinician to make that decision with the patient on need and what is best for them. So we can't advise you on whether or not you should be swapping medications. I definitely speak to your sort of wider clinical team for guidance on how you're managing queries such as that. But it's definitely something that would sit with you guys as the clinical leads on that patient's treatment management.
Yeah, absolutely on that one. Obviously the difference to that is if a patient was eligible for both and the patient decided to swap, or you agreed with the patient the best course of action was to swap, if they moved over to the Tirzepatide for weight loss pathway, and they were eligible for that, they would get access to BSOP. But we couldn't see a patient on Ozempic at the moment for BSOP, unfortunately.
Excellent. I think that's all the questions I can see, Jimmy.
Yeah.
So I think that's all of them, but I mean, by all means, please do continue to pop questions in there. We had a webinar last week, and after today, we'll draw together an FAQs and make sure that that's circulated, along with any additional information. I can certainly contact everybody that signed up today to provide a copy of the curriculum overview and some additional information, but also to make sure that yes, I can share the referral form as well, of course, but also to make sure you've got my contact details. But Tilly's also dropped our main number and email address in the chat there. So any questions, please do reach out. We are here to help. We're here to support you guys in any way that we can to ensure that referral process is as smooth as possible, and help get your patients signed up and supported as quickly as we can, really.